Today, I wanted to connect with you to chat with you about the MED-DBT book and to maybe just have a little bit of an opportunity to, yeah, kind of discuss like what that process was like, what kind of, led to the book, even kind of the idea for the book to start. So, could you share a little bit about, Anita, like the story that led up to this, or just like maybe some of your background so that we have a bit of an understanding of, yeah, what kind of led to that?
I mean, it's hard to answer that in a succinct manner because really the book is the culmination, I feel like, of my whole career in a way. And so, the book represents some of my early experiences coming into eating disorder treatment and the things that I learned um, 20 plus years ago at this point and working in different levels of care, but also my dissatisfaction with some of what I was experiencing and seeing, and sort of my evolution, I guess, into DBT, and then trying to figure out how to put DBT and eating disorders together, and then meeting and working with Lucine Wisniewski, my co-author, in Ohio. That was 2008 and 2009. And the two of us sort of coming together and bringing our similar but different paths together to try to fine tune this framework. And really, so this book was sort of the outcome, I guess, of all of these years of curiosity and client feedback and our own desire for change in the field of eating disorders.
Yeah, absolutely. Well, and I want to come back to that in a moment when you're referring to I know, look at that beautiful book when you reference wanting to make change, because I do want to circle back on that. But first, as you hold that up, can I just ask, like, how does it feel to have it out in the world? It's a
Uh, it's very new to me. I've never written a book before, and I just saw this for the first time a couple of days ago. And it's a bit surreal, and I'm really proud of it. And I think at this point, I'm just curious what people think about it.
Yeah.
You
Because you
share
and
something
Lucine were
that you've been
working on
working
this
on
for 2+ years. I mean,
about
like you
two
said, it's
years.
been in the
Yeah,
making your whole career, but in terms of writing.
yeah, it's a really exhaustive process. So Lucine and I have had been working on this for at least, I would say, 2 years. Um, and so it's a process. It's a learning curve to write a book. It's not the same as writing a manuscript for a paper. It's not the same as a thesis. And we really wanted to write it in a way that was conversational, not academic. And I hope we've done that. Yeah.
And to your point, like you said, you wanted to write it as a conversation. And so I know, again, I have some background knowledge of this book, but while I appreciate that this book is for clinicians, you've kind of said to me, like, and it can be really for anyone who wants to know about a different approach or a different treatment.
I I get asked that a few times now, and yes, the book was written for clinicians in mind, so that if somebody wanted to deliver this treatment, they would have a pretty good sense after reading this book what that looks like, what is entailed. But as you know, Rach, because you've seen me do our MED-DBT caregiver groups, a lot of what I teach caregivers and everything that I teach clients is also embedded in this book.
Yeah.
I would like to write a caregiver companion and a client companion to go to this. But I still would tell anyone that is interested in MED-DBT or interested in um, what it is that I do and what Lucine does. I think this is a really good source. Do
Absolutely.
that.
And so that's what I would like to maybe ask a little bit more about now too, is kind of well, maybe also I might be jumping ahead. We're talking about med-DBT, we're using this language, and maybe I'll actually pump the brakes a bit and slow down to maybe just describe what that is for anyone who might be listening to this and isn't sure. And then I would love to know kind of the why, like why did you and Lucine create med-DBT, maybe after you
Mm-hmm.
try to
Mm-hmm.
describe it.
So I think I forget that we say med, and it's not
Yeah.
always clear what on earth med is. So MED, the M stands for multi-diagnostic, and then ED, eating disorder, and then DBT is dialectical behavior therapy. And we needed to call it something to demonstrate that it was not the same as other DBT for eating disorder adaptations. So this is a protocol that we've fine-tuned over the years for people that have an eating disorder in the context of co-occurring problems with emotion regulation, trauma, substance use, self-harm, suicide, medical instability. And I always like to say that that M for me, while it on the surface means multi-diagnostic, it has always meant misunderstood,
Yeah.
marginalized, misaligned, misdiagnosed. There's a lot that that title means personally. And so for us, you said, why did we create this? Like, why create a whole other treatment? Aren't there treatments already?
Yeah.
And yes, there are really excellent treatments for people that have eating disorders that save lives and that are incredibly important to the field. And not everybody responds adequately to those approaches. And that's where this came from. Who was feeling marginalized, who was feeling misunderstood, and
Yeah.
why were they feeling those ways, and what would treatment look like for them? How could we develop a treatment that was collaborative and that could manage multiple difficulties at the same time, rather than saying, well, we'll talk about your trauma when you've eaten enough, or we'll work on your OCD when you can normalize your eating. We needed something that could meet people where they were without them feeling like nobody could help them.
And I want to, I appreciate that because I think, in other treatments that might be the case, or that might be some of our clients' experiences with those. And so I wondered, yeah, if you could expand a little bit, Anita, on were there moments in your clinical work where you kind of thought like, yeah, something's missing, and that's what led to you and Lucine.
Yeah.
Yeah.
Oh, early on. And you see that more now in the age of social media. People are talking a lot more about what works and what doesn't work, even in a more informal manner. But when I started in the field of eating disorders in the early 2000s, there were lots of things that I didn't agree with or didn't like. Like one of the first ones that stands out to me, I remember working in a day treatment program in Toronto, and a lot of clients would be discharged quite quickly if they were engaging in suicidal behaviors, or if they self-harmed, or if they used a substance on the weekend. They would be quickly discharged, right? And there'd really be nowhere for them to go. And I remember feeling like, well, this doesn't fit for me. Why would we do that? And I remember at the time advocating even to run a group, and this is before I was trained in DBT, but I wanted to run a group just to help people with self-injury and what that meant to them and how to help them tolerate that. And I was not allowed to do that. And there were a number of things that I wanted to add to treatments back then. And there was no flexibility for that. And that those were seen as, I think those were seen as ancillary to or supplements to, and that the real work of treating an eating disorder was making sure people were properly able to eat, and that they were obviously medically stable, and they were at a quote unquote healthy weight.
Yeah.
But that just didn't fit for me. And that is why I ended up, actually, after about 4 years, I ended up leaving eating disorders, and I went to work in the borderline personality disorders clinic at the Center for Addiction and Mental Health. And that was in 2005, I think, 2004. And that's where I was exposed to DBT for the very first time, and to Marsha Linehan and the whole model. And I just fell in love with it. Like it made so much intuitive sense to me,
Yeah.
but it was not adapted for people with eating disorders. And that was my PhD dissertation, was blending these two treatments. And then simultaneously, you had Lucine Wisniewski in Cleveland, Ohio, doing kind of similar work. And then I went to go see her. She was giving a talk in Boston, and a colleague from grad school and we went. And I listened to Lucine and Denise Ben-Porath give this amazing training on DBT for eating disorders. And I went up to Lucine at the end of that, and I gave her my postdoc business card. And I
Yeah.
said, if you're ever hiring, let me know. And she emailed me that weekend. And I went and moved to Cleveland to go work with her. And that's kind of the early days of things
Yeah.
not fitting well, needing a change.
Well, and I mean, first of all, I love to hear that backstory because I think it really helps to understand just how, a lot of these things have been in the making for a long time, right?
Yeah.
Prior to just even putting pen to paper for the book. And so was that the moment for you, Anita, and maybe also for Lucine, where you were starting to notice like integrating emotion regulation within eating disorder treatment, or that the two kind of, you can't separate them, you can't compartmentalize them? Like, is that where some of that started to kind of, we can't really treat
Sure.
the eating disorder and then trauma or, the other things that we oftentimes are seeing with our clients?
I think it was that, but it was bigger than that. It was, DBT is not just about emotion regulation. DBT is about understanding, biology and environment and invalidating environments. It's about relational dysregulation, whether that's over controlled styles or under controlled styles.
Yeah.
And so there's this entire philosophical framework of how to be with people, especially people who have been referred to as treatment resistant or difficult to treat, which were a lot of the patients that Lucine and I were treating.
Yeah.
Right? These would be, and now it's scary because we've got this other label floating around on terminality. And the thing for me is that the same people that are being that are meeting criteria for terminal, let's say anorexia, are the same people I would absolutely treat in MED-DBT. So there are these evolutions in the field that I think are important. But yeah, those were the early I guess seeds of MED-DBT, was that we wanted to treat the eating disorder in the context of these other pieces of this person, whether that was biology, physicality, emotionality, relational, that to ignore that didn't seem to make sense, right? Because I think when you treat an eating disorder as though it is a medical condition, like this isn't cancer that you go in, you extract the tumor, and then you get it out. If it was, then I'd be like, all right, let's just do it. But that's not what it is, right?
No.
And so um, I think that some of those interventions can feel really aversive and invalidating for some people,
Yeah.
not for all people, but for
Yeah.
some.
Okay. I have to say, again, I know so much behind the scenes of just what came to be and how this book, but I wanted to say, or I guess maybe what I wanted to ask is for folks who, maybe don't, like, who maybe don't know as much about both eating disorder treatment and med-DBT, what would you want to kind of, describe to them as like the sparks notes, let's say, of what this treatment, how this treatment is different than what maybe we see in most other standard treatments that are typically the gold standard for an eating disorder?
I think one is the I always, when I'm teaching, I always say how you think about your patient, your client matters,
Yeah.
right? And so if you think about cognitive and behavioral intervention, CBTE, right? How does that model work? The model says, well, we think that eating disorders are caused and maintained by problematic ways of thinking about a person's body, weight, shape, eating, and that those assumptions or schemas or beliefs shape what we do, and so we restrict or we binge and purge in an effort to soothe this, kind of like we would in OCD. I have a terrible thought that something bad will happen if I don't touch the light switch 7 times. So we touch the light switch 7 times, but then it just feeds the thought.
Yeah.
And so early iterations of eating disorders followed a lot of those lines, right? So CBTE will do a number of cognitive and behavioral interventions to try to shift the way people think about their body weight, shape, et cetera, et cetera. FBT is we call agnostic on purpose. So it says it doesn't really matter in this moment anyway, in the early days, what causes this thing. We just need to treat it, and we can treat it without always knowing the reasons. And when you've got a young kid with an eating disorder, you don't want them at low body weights or purging behaviors for long periods of time for lots of reasons, developmental windows, the damage to the organs. And so that model makes a lot of sense, right? Let's act now and we can explore things later when there's more stability. These are important treatments. Large numbers of people respond to these and should have access to them. MED-DBT, while prizes CBT and FBT approaches, we don't throw those things away, but we look at core biological drivers. So that is emotion regulation, but it's also sensory and perceptual biological differences, reward and threat processing differences, metabolic differences. So emotion regulation is one, but we know that eating disorders aren't just problems with emotion regulation. So the model says, how do we work with someone when there are these biological vulnerabilities and these things exist in really significant invalidating environments? Diet culture, Western ideals about beauty, so many things, right, that go on. Eating disorders seen as choices or vanity. And so the model is built on that theory that this person is struggling for all of these reasons. And so when you get into the model, you'll see how we integrate these things over time. I would also say that the model chooses what we call a life worth living, a life worth recovering into. And so we don't just ask people to gain weight just to gain weight, or to stabilize weight, or to eat, or to stop just to stop purging, although there's value to that. We help them figure out where would we want to be, what is the life you would like to have, what is a life that has meaning and purpose, and let's target any eating disorder, self-injury, or other behaviors that interfere with that life that you would like to have. So the North Star of this treatment is a life worth recovering into, not we need to gain weight. Yeah. You need to, that kind of thing. There's a number of fundamental differences, but it's hard to explain in a.
Oh, well, that's why you wrote a whole book on it, right? We can't cover that in just a short video, but exactly well, and I think that's so helpful for you to differentiate, because I think exactly to your point, there's all these other things that even myself as a clinician just felt like I was trying to add in. And it's really exciting that there's now a framework that allows us to kind of see the whole person, right? Rather than the disorders or the presenting problems that we are trying to help them with, right? So I think that's really exciting. And maybe my one, other additional question to that is, being a clinician who also offers this, I would love to hear from you, Anita, like, what has it been like to actually offer this with clients? And what's the kind of experience like? How is that different as a clinician offering this treatment?
I personally, I love it. Obviously, I guess I'm biased, but the book exists, the treatment model exists because it has intuitively felt like the most compassionate way and the most collaborative way and the most anti-oppressive way I've ever been exposed to anyway, to help people figure out what they want to do and how to do it. I feel very comfortable in this kind of framework, but this is a framework too that requires therapists you got to be comfortable with flexibility. Again, any DBT protocol is principle driven. You can't say, here's the protocol, do step 1, 2, and 3, and you'll have this outcome. You have to really understand the philosophy underneath it. But and the feedback that we get from this model is generally really positive. Like, I don't think one model fits for everybody. Like, I don't think MED-DBT is for everybody either. Yeah. But I do believe that the field would benefit from having differential care pathways. I think that CBTE should be one. I think FBT should be another. I think MED-DBT should be another. Anything that is evidence-based and that patients are looking for. CBT for ARFID is another. Like, I think that there needs to be an expansion of what people can access. And I am happy that MED-DBT could be considered for that. I want to also highlight, I think one of the things that's different too about MED-DBT is that it's designed for people in what we call stage 1. This is an important distinction, right? There is DBT for bulimia nervosa, and there's DBT for binge eating disorder. And those are excellent models. We call them the Stanford models because they were developed from Deborah Safer at Stanford University. Those are great, excellent models when a person has a primary eating disorder. So they don't usually have a lot of co-occurring stuff going on. And they're not medically unstable. They're not in a crisis kind of situation. Great. DBT bed or DBT BN. Perfect. But when you've got someone who is really struggling, wondering whether or not to stay alive, dealing with intense emotional pain, there is self-injury, there's suicidal thinking, there's eating disorder severity, they may be in and out of medical severity, they don't know how to feed themselves in a regular manner. You need a treatment that can do that collaboratively. And so MED-DBT is designed for people that are in what we call stage 1. Usually it's referred to as behavioral discontrol. They really do need more help. And they're usually folks that haven't responded to the frontline treatments. Yeah. So I think it's important to know if you're a person with an eating disorder listening to this, I think it's important to know where you fit, and a good assessment will help you figure out which pathway to take. Or a parent listening to this, MED is not for everybody at every stage.
Mm-hmm. Absolutely. No, I think that's really helpful to know, right? And I think also my experience with MED-DBT as well is that oftentimes folks who are maybe looking at MED-DBT, oftentimes they've tried another approach already, right? So they're looking for something different to maybe try and have a different experience. And kind of talking about the why MED-DBT was created and things like that. Can I ask a little bit about this book? We are coming, we work at a private clinic, and I'm curious, this is something that is not just for private clinics. This is an approach that can be kind of, this can inform at all levels of care, all types of different treatments. Is that correct in me saying?
Oh, in my opinion, yes, absolutely. Yeah. I mean, I have been doing work, both Lucine and I mean, we train people on an international level, across levels of care. And so, we've worked with adolescent day programs and inpatient units. We've worked with adult programs to help them even be MED-DBT informed. Like, what does it mean to use the MED-DBT target hierarchy in a day treatment setting? What does it mean to teach DBT skills that are applicable to people struggling with eating disorders? What does it mean to use dialectics on an inpatient unit? That's one of my favorite talks. So it's hard to do the full MED-DBT model in a high level of care because there's competing models. Yeah. But I do think that there's so much that can be used across levels of care. And I know a number of programs that are already doing that, which is really exciting.
It's very exciting. It's very exciting. Mm-hmm. I mean, I'm so excited that this book exists. I'm so excited that not just clinicians, but, clients, parents, caregivers, there's going to be a ton of people who I think are going to want to look at this and just, learn about a different approach, learn about a different way that we think about and can treat, these multi-diagnostic eating disorders. I'm curious, Anita, I imagine, well, I don't know, what was harder than you expected about writing this book? Or was there any kind of, hurdles? I'm sure maybe there's that you didn't anticipate along the way while you and Lucine were coming together to try and, create this framework.
I think that probably one of the biggest challenges was keeping it at a length that wasn't going to be a bit succinct. We had to make a lot of distinctions. We had to make distinctions about how much do you put into the book versus not. Like, I could write this much for each chapter. Like, there's so many examples and so much to say and so much nuance. And so we had to keep coming back to saying, okay, this is too much. Like, we wanted to create a book that people could read that wasn't, so cumbersome that it almost, you kind of put it down after the first chapter. So we tried to keep it, here's the potent information for this section, and here's what we want you to know here, and knowing we'll write more and publish more. But I think that was hard because I I want people to know everything that I'm thinking and all the ins and outs. And so Lucine and I would go back and forth. I think that was probably the most challenging. But I
Can I?
can't say, like, it was really a lovely process. I like writing though. So and then to get to work with Lucine in this way was really wonderful. She's just so brilliant. And so for us to come back together and meet every week and hash out things uh, was really, I love that kind of stuff.
Yeah.
You know what I would say, that the chapter that was probably the most that took us the most time that we kept going back to was a chapter on targeting behaviors.
I can
Um,
imagine why.
yeah, right. Because in MED-DBT, like, okay, here's another core difference, right? In standard eating disorder treatments across levels of care, right? The idea is that you come in and the expectation is you're going to get a meal plan.
Hmm.
Okay, we're going to work on eating 3 meals a day, 2 to 3 snacks a day. We're going to cut out exercise. We're going to really work on the eating disorder in this particular way. And in MED-DBT, that's not a given.
Hmm.
In MED-DBT, we prioritize things like, like, for example, if something could imminently kill you, I think it's in our best interest to try to target that, because I can't
Yeah.
help someone if they're dead. It's just a fact, right? And so the first thing we do in med is target anything, whether that's suicide, self-injury. It could be an eating disorder symptom, but it might not be.
Yeah.
It depends, right? Is the person medically stable? Are they great? Then I may be targeting self-injury before I even
Other higher
touch
needs.
something else, right?
Yeah.
Because if you're dead, right? But for us writing that chapter, it's tricky. Like, how does a clinician who's not a medical provider, how do you know what's imminently life threatening?
Yeah.
And how do we write it in a way that doesn't make it too protocol ish, right? Because
More
the
principle
risk is,
driven, like you were saying.
yeah, because
Hmm.
the risk is a lot of people either put all eating disorder symptoms as imminently life threatening, and they're not,
Hmm.
or they kind of ignore the eating disorder and go, well, we'll just target emotion regulation and hope the eating disorder gets better. And that's not effective either. So we spent a lot of time, and you'll see in our acknowledgement section, there's a number of our colleagues who we consulted with about this, to try to be as, I don't know, accurate and empirically driven as possible.
Yeah.
Yeah.
Can I ask a follow-up question too, in terms of just incorporating other colleagues and people in the field?
Mm.
I know that this conversation is mostly about the book, but can I also just hear a little bit about you and Lucine? There was a MED-DBT conference last year, at the end of last year as well.
Oh,
I
yes.
think this book and you two writing this, like there's also, I think, a lot of other conversations that this has started, and there's a little bit of a movement being created. And so, can I maybe have you just speak to that a little bit as well?
The movement, I mean, I was at a conference, international conference on eating disorders, a few years ago. It was in, I think it was the Washington, D.C. one. Anyway, the keynote speaker was talking about how research flows and how people learn about new treatments. And he said, it takes an average of 17 years for new research, new treatment protocols to actually reach public, sort of the public domain in a meaningful manner. And I remember sitting in that audience, this is a few years ago, and feeling like, yeah, that checks out,
Mhm.
because here I am at least 20 years later, and I'm like, we're just now, this is the most momentum I've seen with MED-DBT, even though Lucine and myself and many of our colleagues have been working on this for decades. It's a humbling experience, right? How long it takes and how much goes into it. So here we are finally. The book, I think, is driving some of this. I have an excellent team of colleagues, Kim Claudette, Charlotte Thomas, Shelley Hindle, and we've been meeting to do advanced MED-DBT consultation for years. And I don't know who it was on that team that said, we really should just do a conference.
Yeah.
And so it's the timing of things is also, I don't know, synergistic. And
Yeah.
so we had the first conference last September 2025, and we're already planning the next one. So stay tuned. Details coming. Uh, and so and now we've got a MED-DBT listserv, and it's just growing, and it's really so cool to see such an international group of people. So we've got people from Singapore and Mexico and Australia, all across North America. It's really exciting to be part of that little community. And though we're small right now, I feel like there's some really good energy behind this, and I'm excited to see what happens in the coming years, for
I
sure.
am too. I am too, and I'll
Yeah.
be closely watching. Okay, so I probably only have one more question for you about this book, and then I'll let you go, which is, and I appreciate it's your baby, so it's like asking you to pick a favorite child or something, but is there a favorite aspect, chapter? Is there something that,
Mm.
stands out to you as something that you're really proud about, or just, yeah, a kind of a favorite element to this work you've been, pouring yourself into for the last couple of years?
I think if I guess I would pick the theory. And when I say the theory, I mean I love the adapted biosocial theory. It's too big for me to explain it here. Lucine and I are actually in the process of recording the two of us talking about these things, and those will be available soon on demand, so people can access that. Like I've always said, I think that helping people understand that they make sense is so important to me. And the minute that any of us feel like we don't fit, we don't belong, we don't make sense, nobody understands, and we feel invalidated in those ways, I think treatment engagement drops. And I know for me, I don't think I could work with a team that I didn't feel understood me on some level. And so the adapted biosocial theory and the way we've adapted DBT assumptions about clients for the people that we treat, I feel really, I feel good about those things. I feel like they represent an important shift. And I hope that our clients feel that too. I mean, I would be very open to feedback as people read this and get access to it. But I think it's very important. This is why when I do day treatment programs, or I know I always say you need to run a You Make Sense group
Yeah.
in which you talk about the theoretical models so people can try them on, reject them, accept them, fine tune them. My greatest teachers have always been the clients that have let me into their lives. The ones for which MED-DBT has worked, the ones for whom MED-DBT didn't work, I've always learned from them. And that's why we dedicated this book to them.
Yeah.
Um, yeah, I hope that they see their influence on certainly our thinking, and they're going to continue to influence. And I'm glad for that.
Yeah.
Really glad
I
for that.
mean, I'm also biased, obviously, because I'm such a supporter of your work, but I think that is actually what comes across very clearly is the way that we think about the clients that we will be, using this treatment with and offer, like how we think about them, the theory, like you were just saying, it is different. And I think that comes
Yeah,
through with how it's, how the treatment is provided, how we speak about clients, how we think about
everything.
like, and
It's
so
everything.
it is everything because if we are actively looking to see and understand them, that makes all the difference, right? And I think that's really clear.
It does. And when you have someone who sits across from you and has had a long history of feeling misunderstood, or coerced, or all the million things that a person can feel as they journey through, I don't know, treatments and things,
Yeah.
you know to ask someone to think about eating or dealing with a changing body, you have to be able to also think about sensory, perceptual, neurodiversity, cultural differences. That all needs to be part of how the two of you decide to move forward.
Yeah.
MED-DBT is not something we force on anybody. If it doesn't feel like the right fit, that's okay. We need
Mhm.
to find something else.
There's
But
almost like safety built within it for those
I
elements.
hope so.
Mhm.
I hope so. That's at least at the heart of it,
Yeah.
for both of us, for both Lucine and for me. And so I would love to hear from people, what they think about it. And yeah, I just feel really fortunate to get to work in this field, I guess, is really at the end of the day. Um,
As do I, and I'm so excited. And
mm.
as someone who has a copy of this book and is currently reading through it, I feel the same. And I think that's why I wanted to hop on a call with you and talk to you about it because I think, um, I know how much passion has been behind this project for you, and I also speak for Lucine as well. But it's something that I know myself, the clinic, other colleagues in the field are also just wanting to thank you and celebrate you for. I know how much work goes on behind the scenes to put pen to paper and to finally have a protocol and a treatment like this finally come out. Like you said, 17 years is the average. So
Yeah.
I just wanted to say, we are so incredibly proud of you. We're so excited to be seeing the copies come in the mail and they're being delivered left, right, and center. Um, and I mean, yeah, I just wanted to maybe kind of, yeah, let you know that we see you and we see how much work and effort has been put into not just this book, but also to the work you do with your clients as well, because I know that all of that has, of course, influenced this. So I just thank you for
Thanks,
chatting with me about the
Rachel.
book. Uh,
Well, and of course, like the book doesn't exist if you don't have teams around you. Like the treatment is about teams, but so is so a big shout out to us, to my team, Center for Psychology and Immersion Reg, and to Lucine's team,
yes. Mhm.
right? CEBT Ohio, right? So both of our teams have been so supportive and so helpful, and just like that energy behind us was really helpful, because when you spend 2 years trying to write something, it can be a bit grueling at times, and you kind of think, why am I doing this? Is
Yeah.
anyone going
Mhm.
to read this
Well, that
anyway?
was one of the questions I was going to ask. Like, did you have any moments where you thought, are we really going to actually get this thing published?
Oh yeah, oh yeah. Which is why I think writing with somebody is really helpful. I think that Lucine and I work well together, and I think we had a lot of fun with it. I'm so glad. And now we're trying to record big chunks of it so people have some access to it in a different way. And so I'm
That's what
just
I
really,
wanted to
yeah.
ask you. What can we keep our eyes peeled for? So some trainings or some
Mm,
some videos from you and Lucine coming, maybe talk
yes.
of the next MED-DBT conference. What should folks
Yeah.
know about coming up, I guess, in the next year?
Um, all of that and more. So, like I said, Lucine and I are recording sessions right now that will be available on demand. So that's coming. I don't know exactly when. I'm hoping we can get some of those out by spring. We did record a summer series. It's available through Lucine's website. Maybe we can put that link when we post this so
Yeah,
people can
sure.
access that. So that there's three different, 90-minute webinars you can watch. Uh, Lucine and I will also be at many of the major conferences. So you're going to catch us International Conference on Eating Disorder. You're going to catch us at Eating Disorder Association of Canada this year. There's a lot of places that we're speaking and just holding workshops. The next MED-DBT conference is under tight wraps right now. I'm not at liberty to share those
Top
details yet,
secret?
but that's
Okay.
coming out soon. So there is a MED-DBT conference website. Stay
We'll
tuned.
link
I
all
would
these
say
things in
all
this
of these things, yeah. And I would just say stay tuned to our socials,
in
both
the
mine
list
and
if
Lucine's.
people want.
Yeah, I think if people can follow, we're trying to post what we're doing on things like LinkedIn or
Yeah.
Instagram, Facebook. That's where you'll find the most up to date stuff on what we're doing.
Excellent.
Um, yeah.
Well, congratulations. What an accomplishment it is
Thank
to be
you.
a published author. It's so
Yeah.
exciting. And just again, thank you, not just on behalf of me, but the clinic, the field. Like, thank you so much for all of the work that has been put in. This also extended to Lucine and her team as well. We couldn't be more proud of you. And thank you for chatting with me a little bit about it today.
Thanks, Rachel. Thank you.